Welcome to MBBS Mastery. This is the first lecture in our gastrointestinal medicine series, How to Approach a Patient with Gastrointestinal Diseases. In this lecture, we'll break down a structured approach, covering history taking, alarm symptoms, physical examination, investigations, and management, exactly how you'll be expected to do it in exams and clinical practice. If you're following this series, make sure to subscribe and turn on notifications so you never miss out a lecture. Also, check out the full playlist for more medicine lectures. Let's begin. When evaluating a patient with a suspected gastrointestinal disorder, our approach must be systematic. It involves understanding the anatomy and function of the GI tract, identifying common symptoms, taking a thorough patient history, recognizing alarm symptoms, performing a detailed physical examination, selecting the right investigations, and finally, formulating a management plan. But first, understanding the GI tract is fundamental, as it is a continuous hollow tube extending from the oral cavity to the anus. You've already covered this in anatomy and physiology subject, but here's the quick review. The process of digestion begins in the oral cavity, where food is chewed, mixed with saliva, and prepared for swallowing. The esophagus is a muscular tube responsible for transporting food to the stomach using coordinated peristalsis. The stomach serves as a temporary storage chamber where acid and enzymes break down food, forming chyme. This chyme then enters the small intestine, which plays the most crucial role in digestion and absorption, allowing the body to extract nutrients, electrolytes, and water while also regulating immune responses against harmful substances. The large intestine then absorbs remaining water and electrolytes while storing feces before excretion. The anus serves as the final outlet for waste removal, regulated by internal and external anal sphincters. Any disruption in these functions leads to GI symptoms that we commonly encounter in clinical practice. Now, let's take a step back and think. Imagine you are in your clinical rotation and a 55-year-old male patient presents with difficulty swallowing, weight loss, and a history of long-term acid reflux. What is your first thought? Could this be GERD, or something more serious like esophageal cancer? This is why a structured history is crucial in guiding our differential diagnosis. Patients with GI disorders may present with a variety of symptoms. Dysphagia, or difficulty swallowing, can indicate structural obstructions, neuromuscular dysfunction, or esophageal motility disorders. Dyspepsia, often described as indigestion or discomfort in the upper abdomen, may be related to gastritis, peptic ulcers, or gastroesophageal reflux disease. Heartburn and regurgitation are classic symptoms of GERD, where stomach acid flows back into the esophagus, causing irritation. Vomiting can be due to infections, metabolic disturbances, or obstruction. Upper GI bleeding presents as hematemesis, which is vomiting of blood, or melena, characterized by black tarry stools. Lower GI bleeding, on the other hand, presents as hematochezia, which is the passage of fresh red blood per rectum. Diarrhea, characterized by increased stool frequency and decreased stool consistency, can be caused by infections, inflammatory bowel disease, or osmotic imbalances. Conversely, constipation occurs due to low fiber intake, mechanical obstruction, or neurological conditions. Abdominal pain is one of the most common complaints in GI medicine and can be visceral, presenting as a dull, poorly localized pain, or somatic, which is sharp and well localized. Identifying the nature of the pain and associated symptoms helps in narrowing down potential diagnoses. A proper history is the cornerstone of diagnosing GI diseases. We use the ODPARA framework, where we begin by determining the onset, whether the symptoms appeared suddenly or developed gradually. Next, we assess the duration to differentiate between acute and chronic conditions. Understanding the progression helps us determine whether the symptoms are worsening or resolving. We then inquire about aggravating factors, such as spicy food worsening reflux, and relieving factors like the use of antacids in GERD. It is essential to ask about associated symptoms such as weight loss, nausea, vomiting, diarrhea, constipation, or fever, as they provide valuable clues for diagnosis. Now, let's test your understanding. If a patient presents with progressive dysphagia, first to solids and then to liquids, along with unintentional weight loss, what is your top differential? Think about it for a moment. The answer is esophageal cancer, particularly squamous cell carcinoma or adenocarcinoma. This is an example of how history alone can give us a strong diagnostic clue. While common GI symptoms can often be managed conservatively, certain alarm symptoms indicate a need for urgent intervention. Unintentional weight loss and anorexia may suggest malignancy or chronic infection. Upper GI bleeding, which manifests as hematemesis or melena, is a medical emergency that could indicate peptic ulcer disease, esophageal varices, or gastric malignancies. Lower GI bleeding, presenting as hematochezia, may be due to diverticulosis, inflammatory bowel disease, or colorectal cancer. Persistent vomiting is another red flag, as it could indicate gastric outlet obstruction, raised intracranial pressure, or severe metabolic disturbances. Anemia in a GI patient is concerning, as it may suggest chronic occult bleeding from a malignancy. If a palpable abdominal mass is detected on examination, it raises concerns for an underlying tumor, organomegaly, or a cystic lesion, necessitating immediate imaging and biopsy. After history taking, a thorough physical examination is crucial. We begin with a general inspection, noting signs of pallor, which may indicate anemia, jaundice, which suggests hepatobiliary pathology, or dehydration, which can be seen in persistent vomiting or diarrhea. Oral examination can reveal ulcers, suggestive of Crohn's disease, or nutritional deficiencies, while dental erosions may point toward GERD. Moving to abdominal examination, inspection can reveal distension or visible peristalsis in obstruction cases. Palpation is performed to assess for tenderness, hepatomegaly, splenomegaly, or any abnormal masses. Percussion helps evaluate for ascites, while auscultation of bowel sounds provides insight into peristaltic activity. Hyperactive sounds suggest obstruction, whereas absent sounds may indicate ileus or perforation. Approaching a GI patient in medicine requires a logical, step-by-step evaluation. A structured history, careful examination, and targeted investigations help us arrive at an accurate diagnosis, ensuring effective treatment. Let's wrap up with a quick case scenario. A 40-year-old woman presents with chronic epigastric pain, relieved by eating, but worsens a few hours after meals. What is the most likely diagnosis? I'll give you a moment to think. That's right. Peptic ulcer disease, likely due to H. pylori infection or NSAID use. Recognizing classic presentations like this is key to mastering GI medicine. This concludes our first lecture in GI medicine. Stay tuned for our next lecture, where we will discuss gastroesophageal reflux disease and peptic ulcer disease in more detail. If you found this lecture helpful, make sure to like, share, and subscribe to MBBS Mastery for more medical lectures. See you in the next lecture.